And we're live in 5,
4, 3,
2,
1.
And we are live. Good morning, everybody. It is Wednesday, November 19th, 2025. My name is Jens Chapman, and today is a very special day because we have a dear friend and colleague from within the city, but miles away, no, just 1 or 2 miles away in a different healthcare system. Dr. Louie come back again. He's going to talk about the importance of preoperative planning in spine surgery. We thank Medtronic for their sponsorship. My name is Jens Chapman, and welcome to STED Talks, Spine Technology Education, and the multidimensional D. This time the discovery, debate, discussion is enhanced by degrees. You'll have a lot of degrees referred to by Dr. Louie, and there'll also be another dimension of D, that's digitization. As always, and 4 clinical fellows are right here, right now. They are going to present some cases. We're going to ask Dr. Louie for some sage advice and thoughts. There are no curveballs in there, there are no weird things in there. They're just kind of life in the big city. And no particular order, actually in some particular order, for some reason, we'll ask Hagai to come here, Hagai Amstakan. And he has a case that I'm responsible for. And Dr. Louie, we would appreciate your insights. Again, no tricks in there. Amsta, come on up here.
Hi, good morning. Thanks for the introduction, Dr. Chapman, and thanks for coming here, Dr. Louie. I'm presenting the first case. This is a 60-year-old female. She came to our clinic due to crippling back pain and the forward and lateral truncal posture. She describes her worsening pain over the last few years, worsening postural collapse to the point where she's limited in her daily activities. Medical history is significant for hypertension, hypothyroidism, but nothing significant, no major surgeries other than shoulder replacement. On her exam, there were no overt motor deficits, no bowel bladder symptoms. There was some numbness and tingling in her anterior thighs mostly. Her DEXA scan was mildly osteopenic, but no osteoporosis. She has been doing PT. She had several epidural injections. She's even been using a TLSO with some relief, but continued degeneration of her symptoms. Socially, she was an office worker, and she was also caring for her quadriplegic husband. That's her first imaging that we had, the scoliofilms, and you can see she has thoracolumbar kyphoscoliosis and dextroscoliosis. The upper end of the curve is about T8, and that's her spinal parameters. We can also see on a CT myelogram to better appreciate the deformity. We have both the sagittal and coronal views, and we can see there's listhesis, both anterior listhesis and lateral listhesis. We will play just a sec, yeah. And you can see the axial views on the left of the specific levels. The stenosis is worse in L4-5, where they have the most significant lateral listhesis. That's the MRI. Again, showing the same findings, and you can see worsening stenosis, both central stenosis and foraminal stenosis on the lumbar levels worsen L4-5. So to summarize, a 63-year-old female, severe back pain, postural collapse, thoracolumbar kyphoscoliosis, dextroscoliosis, with hyperthoracic kyphosis, loss of lumbar lordosis. She has central and foraminal stenosis in multiple levels, and listhesis, as we saw, no neurological deficits. I'll open the
Dr. Louie, Philip, thanks for being here this morning. It's really cool to have you. Did you see this case? Did you
Yeah,
follow?
yeah, yeah. I can
Yeah.
follow on. Yep.
I'm going to ask you a very naive question.
Sure.
So why did this happen? This lady's a flipping saint. She works full-time for a municipality here. She takes care of a quadriplegic husband, meaning quadriplegic as in quadriplegic. And she's the nicest person on the world. I could not identify a clear-cut inflammatory arthropathy. I'm paranoid about missing that. She had bilateral shoulder replacements, as you see.
Yep.
But what the heck is going on? And according to several statistical sources, adult degenerative, or how we're going to call them, deformities are dramatically rising. And this, I think, qualifies clearly for a pretty substantial thing. So, question, what's going on here? Why did this happen?
Yeah, I look at these patients. I agree. You know, what we've also seen recently is I've seen X-rays in patients who had X-rays maybe 10 years ago, and everything looked great in their early 50s, and then something happens in their mid to late 60s, sometimes early to mid 60s, like this patient is, and there seems to be a progression of what used to be like a very mild sort of spondylotic presentation. You know, I look at some of these patients and she's got degenerative changes throughout her thoracic and lumbar spine. Like there's some underlying, it may just be, you know, osteoarthritic. She's got bilateral shoulder replacements. That right hip, I mean, both hips don't look great. They just may not be symptomatic yet. We don't see the knees here, of course. My guess is that she's got an element of degenerative joint disease there as well. Part of this is probably, I tell some of these patients, you can blame your parents a little bit because there probably is some genetic predisposition to just the standard osteoarthritic degenerative changes that we see. But I agree, right? One of the last things we want to miss is some sort of inflammatory disorder that's driving this. And then you sort of quote unquote fix the spine, but you don't address the disease burden that's generating or causing a lot of this deformity. But yeah, when I look at this and I hear this story, I feel bad for these people. But she's got elements of these degenerative changes in sort of multiple joints and throughout her spine.
So in absence of a neurologic compromise like myelopathy, she has some weird numbness, which might be foraminal stenosis in the lower spine. She does not have any overt cauda equina, conus medullaris cord compression anywhere. She had MRI scans. You see a spontaneous block vertebra formation, which again would lead me to think that there's some inflammatory disease. But I assume you're not going to race a patient like this to the OR. So outside of checking for bone density and non-spinal segments, what do you do for a patient like this to kind of get to know them beyond the angles?
Yeah, I mean, I always ask them, like, what's driving their pain, right? Is it predominantly back pain? Is that coming from, the scoli or the degen scoli that's there? Or is it predominantly leg symptoms? So it may just be from, like you mentioned, the foraminal stenosis from the fractional curve at 4.5, 5.1. But ultimately, I think physical therapy is where we often start, depending on the chronicity of their symptoms. I think trying to identify the generators and the mechanisms of what worsens their symptoms, what aggravates, what alleviates. We're talking about like lifestyle modifications, especially if they're smokers or depending on, sometimes her BMI looks fairly reasonable from these standing x-rays, but if there is sort of this BMI pandemic, we talk about weight loss and we have them work with their primary care physician as well, just because we know that if patients who are overweight lose some weight, oftentimes they just simply feel better as well. It's certainly a combination of that. I mean, I think RFAs or medial branch block RFA pathway is a little bit controversial for sort of this facet-mediated back pain that may be present. But, we know that if it's the curve that's driving her pain, the surgical intervention is not a small one. So we do everything we can to keep them away from us for as long as they can.
I actually totally agree with everything that you said. And again, this is a pretty harsh case of a mainly lower thoracic kyphosis with a relatively minor lumbar degenerative scoliosis, but she has a substantial reactive lumbar hyperlordosis. How long do you drive non-operative care? I mean, this patient is a saint. She does not have any vices. She is not obese. She's lost, I don't know what, 3-4 inches height.
Yeah, and she's swimming, she's doing PT, she's
She's
doing
doing
everything she
everything
can.
that we've said, yeah. How long do you follow patients in this regard? Do you keep them going for a while, or how long do you drive non-operative care? And who do you trust with that? Is there a physiatrist in your group? I know you had a legendary multi-specialty group at Virginia Mason. Do you still have that?
Yeah, we still have that sort of multidisciplinary group. I think part of it depends on when we see them in their progression of their disease, essentially, right? If we're seeing them as an initial consult, wow, we will let it ride out for a while. I think oftentimes for your system and our system both, right? These patients have tried a lot by the time they see us. Um, you know, patients always ask us, when am I ready for surgery, right? Like, when do I have to have surgery? And then barring obviously the emergent and urgent situations you brought up, we don't have a great answer. It's when they're ready, when they feel like they've exhausted everything, when they feel like they are willing to put up with the risks to gain whatever benefit is achieved with surgery. I mean, I always think 6 months is sort of a ballpark figure in the absence of, a neurologic deficit. But, it really is as long as they possibly can. I think a lot of it, one of the major factors that drives their decision is what are they trying to get back to? Are they already retired and they're trying to return to comfort or sort of hobby activities, or like, are they still in the workforce and need to get back to work? That can often drive the decisions that they need to make. So what sort of risks are they willing to take, or what have they already taken? What sort of support do they have at home? And what does their caretaker situation look like? For hers, it looks like it'll be a difficult one since she's the caretaker to someone who's already struggling quite a bit.
You insightfully put your finger on the hot button there. So the care situation at home is difficult. She has 2 daughters, but they're living remotely. She is the care provider for her quadriplegic husband, and she has a full-time job as an administrator, a senior role in the local city here. So this is truly and amazingly no vices. And again, I told her, go swim. She has osteopenia. So tell us about your system. So as close as it is, just a couple of miles down the road, integrated osteoporosis care is so difficult. She's only osteopenic, so by federal guidelines, she would not qualify for medications. Do you try to put osteopenic patients on bone-building drugs, or is that a mute cause because, again, insurance companies will just go algorithmically and not pay for it?
And you walked into one of like our biggest stressors and headaches. I've got a great partner who's trying to build Venu Namani, who's trying to build a bone health program here right now, because I think that's one of the biggest struggles. I think that if we look at the field of endocrinology right now, it is a busy field and hard, especially locally, to get patients established care. I think these days with the diagnosis of osteopenia, it's really hard to get them anabolic medications, and they're also just really expensive medications. We do everything we can to plug them in, at least with their primary care. We try not to be the ones that are driving their medications, just because I think that, people could argue that we don't have a full understanding as to the mechanisms and how to best prescribe those. But even in the osteopenic setting, I think it's always great to establish care either with their primary care provider or with an endocrinologist to at least, hey, if we're considering some sort of surgical intervention, we do want to do everything we can to sort of maximize the bone health before we start instrumenting. But, it is a difficult situation, I think, in a lot of programs right now, and trying to establish like reproducible bone health care.
Yeah,
and some places have done it well.
Don't feel bad about you. We had an integrated bone health program, and in the series of cost cutting, somehow that has fallen by the wayside. And we've regressed to an improvisational stage and are in a reactive phase of healthcare. Rod, I'll ask my partner here, Phil. Yeah. How high, what would you do? Again, assume this patient's done everything as Chagai has talked about. When would you consider surgery, and how high, how low, how to go? You're a master of X-lift, for instance. You taught us all how to do that. So tell us a little bit about your surgery before I turf the question over to Dr. Louie.
I think bone density.
Yeah, so
Hounsfield
she's there.
units.
She's 1.6.
Yeah. Hounsfield units are obviously important. And the trouble with her is she's got really bad thoracic kyphosis. And I would try not to operate on this lady. You know, I mean, I know she's not doing well, but I honestly, I mean, my clinic is filled with, patients like this where they're kind of at the end of the rope. But I think, I mean, I would try to kick the can down the road.
Which we did, right, Amster? So the can has been kicked down the road. Philip, I kicked the can. How long? I saw it like 2 or 3 years.
Yeah, something like that.
Quite a while.
It's a long time.
Actually, she broke her rib hitting her pelvis because her trunk was so.
Yeah, so the imbalance and the vertical collapse of her spine was so substantial, she broke a rib spontaneously just from rib impaction. She actually developed a hyperostosis there, which I sent her to thoracic surgery for. And the main thing that I had, I'm going to tell you something crazy. I'm a spine surgeon, not a psychiatrist, but my main worry was that she was a silent depressive, so a high-functioning depressive patient, because there's no way that you can, like, for 20 years go on taking care of a quadriplegic spouse and have a full-time job and not be depressed. I thought she was depressed. I'm not a psychiatrist, okay? I asked her every single time about how she's doing and asked the usual questions, but I kicked the can down the road so long until she had her husband in a care facility. And she had finally succumbed to the thought or arrived at the insight that her husband needed to go to a care facility, that she just couldn't do it anymore. So between depression and having a forward stoop posture to try to save him and serve him, I think this is where this came from. And she goes to the pool, does bite her rotten shoulders, and does everything I've asked her to do, self-directed also, which is one of my key things. So Philip, Dr. Oskuian answered in a big picture perspective, and I was not very specific. She has now arrived. She comes to you, she says, I've settled all the things that you've told me to do. I can't live like this. I've broken my rib, 2 ribs actually. Fix me. So, Dr. Louie, what would your advice be to her? How high, how low, how to do? And they hear that you're a minimally invasive surgeon. They know that this Chapman guy does conventional open incisions. So what would you tell her to make this least traumatic but most functional?
Yeah. Okay. So I can no longer kick the can down the road. Thank you for putting that back up. So you're right. She's got this hyperkyphosis. So if we talk about UIV first, yeah, I can't really count, but like a T10 looks like you're right in the middle of that.
Yep.
The apex of the kyphosis there. And so as we all know, that may not be an optimal UIV and stopping point, as there's the biomechanic forces right above the UIV at that point would certainly increase the risk of PJK, even if there may be some autofusions in the thoracic spine already. So we may be looking more upper thoracic here, probably to like T4 to at least clear the apex. In terms of where the base of your construct goes, oftentimes if you're going to try to, I'm guessing this is degenerative in nature and fairly spondylotic, so it's not going to be your younger patient that's got a very flexible deformity here. Setting the base down to the pelvis is not wrong with the long lever arm to prevent future junctional failure from a DJK perspective. She also has those really weird leg symptoms in the setting of what I'm assuming is foraminal stenosis at 4-5-5-1. So I do think at least correcting that foraminal stenosis and just being careful not to throw her off to the left when doing so, because she's fairly balanced from a coronal standpoint. So my guess is I would probably go down to the pelvis, ensure that the foraminal stenosis that may be driving some of the leg symptoms is improved. And then probably going up to T4, inner bodies of choice down below.
You read my mind, T4. Okay, so Haggai, we have to keep moving forward, but these are all very important principles. You see this degenerative process went down to L5. We're not going to stop at L5 in her, so we went to the pelvis.
But Phil, would you go, so you're talking about just going posterior only?
No, I mean, I think you can, I'd say it's dealer's choice, right? If you wanted to go anterior 4-1 and get some anterior fixation there, you can do T-lifts down there depending on if you have an access surgeon or what you prefer. But I do like inner bodies at the base of those constructs.
So you would do 2-level ALIF and then go posterior?
Potentially, yeah.
Okay.
How would you address that transitional zone at the proximal junction? Would you augment? Would you?
Yeah, I mean, you can do some PCOs to loosen up. 2-3 looks like it's auto-fused.
Yeah, one level is,
So,
I said that I think she has an inflammatory disease like
yeah,
psoriatic,
it looks a little
she's
weird.
never been
Yeah.
given a tissue diagnosis. So, and inflammatory parameters, you got the whole inflammatory panel was negative. All right, take us forward.
Correcting the thoracic kyphosis, Phil, is not going to be easy on this case.
Yeah.
No, this is not like a MIS perk
I mean, this is
situation.
not.
I don't think you're not gonna be able to achieve anything except for fixation if you try to do this percutaneously.
Agree. All right. So this is what we did. All posterior. How many? 1, 2, 3, 4 level IDOs.
Yeah. We so a wide decompression from T12 to S1 with osteotomies and cages at L1-2 and L3-4 on the left and L4-5 and L5-S1 on the right. And a fusion from T3, like you said, to the pelvis, quad rod construct, crosslinks, proximal hooks at T3. Still some thoracic kyphosis, but much better lumbar sagittal and coronal
And
alignment.
clinically, how'd you do?
Clinically, she was doing very well. She was very happy with her posture. She still had some numbness in her thighs, but nothing other than that. No deficits.
And vertical height gain was like 8 centimeters or something,
something like that,
So
yeah.
just by straightening out again and resurrecting the lumbar spine and reinflating it, I think we did 4 levels. We skipped L2-3, obviously, but we went 3 levels below. Fire away, Phil. Fire away, Rod. Fire away. Dr. Kramer has joined us now also, so fire away at me. What's going to happen? Is this okay? Is this too high, too low? Did we meet, start with you, Dr. Louie. Did we meet alignment parameters? I'm not giving you an EOS here because we don't have an EOS.
Yeah, either do we. Yeah. I don't see all the measurements, but it looks better. So it passes the eyeball test. Heads over to the pelvis. The O1K looks reasonable. The hyperkyphosis is improved. The lordosis kyphosis junction looks smoother. She's certainly standing taller. The coronal degen curve is improved. Yeah.
Rod, what's going on
The
rosterly?
only thing, obviously, it's always easy to be critical of a difficult case like this. I think the part of the reason why I started doing a lot of robotics is because you get distal junctional failures. And so I do think she's at risk for that. And you can see she's starting to pull out her hook.
Distal, you mean proximal junctional failure? Distal, proximal,
Distal,
upside, down,
proximal.
So how's a robot going to prevent that?
Well, so again,
robotic hooks are better?
no, I think you can put in fascial screws at the top.
Transfacet?
No, just like not have to expose, as high up.
Yeah, so the hooks I put in, I leave everything, our fellows deserve the credit. They are very good at preserving the proximal junction, and we actually just kind of carefully splay apart the muscles. The entire midline and fascial structure and insertion stay intact. So we just do this little parasagittal incision. It's probably more denervating, but this is, I think, one of those things where I'm not sure that this is hype versus reality. I know there's some numbers out there, but they're always from interested parties. And I don't know. I mean, the hooks actually do help. We had a presentation at SRS that showed that, and it supported the work by Newton and Sukin Shah, our new SRS president, that actually showed that hooks are pretty good. We had a novel banding system, but it didn't show any superiority to hooks. Now, they're not ideal, but they allow some pivoting of the spine, and we see that she's developing an upper thoracic kyphosis. Now, take it forward, Hagai.
Yeah, so that's 1 year follow-up after surgery.
Wow.
We can see she's starting to fail. I would add that she was involved in a car accident. She had a broken sternum, and she broke one of the rods. So we can blame that and not our surgical result. But the thoracic kyphosis is somewhat worse. There's lots of purchase of the hooks. The T4 pedicle screws are cutting up, and there's some wedging of the T4 vertebral body.
So I think the saga will continue. So the car crash was bad enough she actually broke her sternum. Okay, but there's an undeniable proximal sag. So her neck is starting to drift forwards. And again, this woman has a generally athletic disposition. She's osteopenic. She was denied anabolic drugs, which in an ideal world, you can see her sternal fracture actually. So she's healed that. So she's actually lucky. This was a pretty substantial crash. We're not talking about a little rear end collision. So is this time to intervene? She's not myelopathic. She has a little bit more of a proximal sag. And if so, how high would you go? Does this mean that we have to commit her to a C2 to thoracic fusion, or when to call what in absence of neurology? Phil.
Yeah, I think this is hard. I think some people would try to go subaxial cervical spine to see if you can get strong enough fixation to bring her back. Um, we hate the idea of these like stage C2 to pelvises, but she may be on her way there. I think the biggest concern with her and her bone density is if you stop short of that, are we just, it's not just a bridge to the next operation. Yeah, I think you have to consider C2 here, but you can certainly, if you can get strong enough fixation in her bone and stop some in the mid subaxial spine, you could consider it. But I mean, that she's really starting to sag forward quite a bit up top.
So, yeah, Dr. Kramer's here. Dr. Kramer, have you, when you're a fellow, you saw a couple of those cases. We've sometimes stopped at T1 or C7, but yes, C2 is inevitable. So right now she's not there. She is overall still very pleased with the surgery, but she has a little prominence now for rods. Would you sometimes just take out the upper end of the rods and see what happens? And again, your thoughts of why did this happen? I mean, outside of the car crash, she had some sag before that.
Yeah, I probably multifactorial. The one thing we haven't discussed yet is the muscle envelope, and I've even looked at the paraspinous muscles up at the upper thoracic region. And I do wonder if, she had some sarcopenia, which potentially was a part of the equation as well.
Yeah, so sarcopenia has emerged as one of the big variables. I hope we'll get our paper submitted soon. We have a larger project in this, which again underscores that sarcopenia is probably actually more important than osteoporosis, so bone density. And we did try, and this is a very enlightened patient, everything posturally, so keeping her ears over her shoulders and pelvis, et cetera. But here we are, so the battle of the mobile spine versus the immobile spine. And yeah, one spanning rod break that was visible only afterwards. Not sure how that can happen because the lumbar spine is actually fused. So do you do quad rods, Phil, or multi-rods for these patients?
Yeah, oftentimes we'll do quad rods.
Yeah. All right. Any other thoughts or criticisms? Otherwise, we'll go to, who is the fellow? Yeah. Dr. Mohammed El-Haroushi has been the opener of the doors to our ER last night. Thank you, Amster. So Mohammed will take the podium next. And he's prepared a case that he did with Dr. Oskuyan, so we can now fire at Dr. Oskuyan. It's only fair, right? I don't know anything about this patient, so I'm curious to see it. But I assume that he'll use some higher tech things than what I do.
I have to run off for like 5 minutes. I'll be right back.
Yes.
I've actually started doing more A-lifts. I think that helps, especially in these longer constructs.
How do you want to get more lordosis than with this?
Well, no, I think the lordosis was amazing on that case. So I think, you can obviously do IDOs and get good correction, but I think, on a case like that, that's a really difficult thing to do posteriorly.
Yeah, I want to save patients from having to raid their retroperitoneum. For me, I love the anatomy. We have excellent access surgeons, but I want to know that the retroperitoneum is still there for taking, and it's an option to go from the front versus the back. I'm not sure in any comp studies I've seen, there's no time saving between anterior plus posterior versus posterior only. So it's surgeon convenience more. And just thinking about myself, knowing what I know, I would not want any surgeon to invade my retroperitoneum unless it was absolutely necessary.
Mohsen had a comment.
Yes, microphone.
Just press the button.
I have a question. Actually, we had many patients like this. We did with Dr. Chapman. That was great surgeries. So my question, most of them are like frail patients. Is it possible like do 2 stages surgery, like put in the screws and laminectomy, and then next step, a couple of days later, do the IDOs or VC or whatever?
That's actually a really good question. Thank you for that question, Mohsen. We actually used to do that in my time at UW. We'd routinely stage these larger cases as 8 levels or more, and do exactly what we said: exposure, screw placement, check a CT, maybe temporary rods, and then bring them back. The question was always how many days in between. And clearly, you want to wait for a couple of days, ideally almost a week, but that usually means that the patients, for the most part, can't go home. So the hospital stay would get into the 2-week realm. So there's not an ideal answer. It depends upon your society, your hospital system. But one of the key things nowadays in our hospital system is that they don't like inpatient stays. And 3 days is on the lower edge. That's when the German studies in trauma have shown the highest rise of trauma enzymes, as they call it. So the trauma cascade is at its worst at that point in time. The inflammatory response rises. So you want to wait for more than 3 days. So most patients, after big exposure like that, can't go home. Rod, any thoughts on staging? We obviously do it if there's a medical problem.
I really like staging. Do A-lifts, do lateral, go home, bring them back. That's. I don't like to do this prone lateral and try to put in. I like to get them out and get them back.
All right. Mohammed, show us what you did recently.
Good morning, everybody, again. So this is a case for Dr. Oshkuyan, 33-year-old female, negative past medical, negative past surgical. Her main presentation was severe back pain and progression of her scoliosis. Her exam was fine, no significant deficits, sensory or motor, and this is the X-ray she came with to our clinic. So the lady has been struggling with scoliosis since early ages. We don't have a previous scoliosis X-ray, but as per her report that it's progressing 10 to 12 degrees. So looking at this X-ray sagittally, she looks balanced. Her SVA is within the normal range. Coronally, it's a balanced spine, but we have this major right thoracic curvature around 70 degrees and a compensatory curve in the lumbar spine around 40 degrees. Calculating her parameters here, her PI is around 51. Lumbar lordosis is around 66, so the mismatch is around 15 degrees. And yeah, so we worked her up in clinic. So this is her lordosis, her Cobb's angle, and a CT Milo and full spine MRI were done. Nothing significant per these studies.
Very small pedicles.
Yeah.
Almost non-existent on some of the
Yeah.
axials.
And yeah, this is her presentation. So what do you think? This 33-year-old childbearing, she had this.
So give me her curve degrees again. What's the main Cobb angle in the thoracic spine again?
It's around 70 degrees in the thoracic spine, measured at T7 down to L1. Her thoracic is around, her compensatory curve around 40 degrees. Her PI 55.
Yeah.
Lumbar lordosis 66.
So these are very controversial cases because in the big picture, if you just look at it from the front, she's balanced.
She's
okay.
balanced.
So she's not imbalanced. She has no neurology. She has a pretty good sagittal balance also. So coronally and sagittally, she's balanced. These patients without neurology and a balanced deformity, I usually get to know very well. Like I tell them, I'm not going to touch you for a year or 2 or 3. Now, a severe curve after 60 degrees, you start thinking about surgery. She clearly had a significant rotoscoliosis, so the rotational deformity is how much on the axial CT. I want to point out, Mohammed has not slept last night, so he's an amazing guy, and he did a terrific job handling elective surgeries and then running in and out of ERs and consults. So he put this together. Do you know how much rotational deformity is?
No, I did not
Yeah, Rod, roughly, is it like 50 degrees out of plane in terms of axial rotation?
I would say more.
The key thing that I always refer to is the famous Iowa study. by Philip Weinstein et al. With 25+ years follow-up of non-operative care of severe adult deformities. And again, they seem to actually do very well or reasonably well. There's controversy around that, but in terms of the longitude of follow-up, this is hard to overcome. 25 years plus, and nobody moves out of Iowa. Your in-laws still live in Iowa, right, Rod? So they've resisted the temptation to move to the West Coast. So this is very controversial because in textbook language, we would fuse this. I would treat this patient non-surgically for years, literally, and they'd have to be very compliant with this because there's no rush in this unless I give them annual follow-ups, I check their alignments. And I get most of my patients do well. Now, I don't like her chest dysmorphism. She clearly had significant rib anomalies. I would want to understand what bothers her. She has a straight clavicle line. She has relatively symmetric breasts. Is it the physical appearance? Is it pain? Are there other factors to involve? I would make sure that she participates in a Schroth method, a formal Schroth method PT, so that they are enlightened about vertical self-elevation through muscle activation. I would make sure that she's compliant in all regards of physical wellness and subjective well-being. But that said, Rod, you obviously went for surgery. What prompted you for surgery? When did you change from non-surgical care to surgery?
Honestly, all the above. I'd seen her for years, and she just, she progressed.
She was desperate for surgery. She saw multiple other surgeons for that. She wanted to have this correction.
And I think, we did have there's some outside films, if you look,
I did not find it. This is
Whether
the
or
first
not-
film
okay.
I have on the system.
She did progress. It wasn't much. It was
10,
like
10,
6,
10 to
7.
20 to 12 degrees.
Yeah.
As per the report.
Yeah, over 6-7 years, it was like 10 to 12 degrees. So I agree. This was a very difficult decision. And like you said, Jens, I get to know these people. I think I saw her for almost 3 years. So.
Okay, so then levels, upper thoracic spine to lumbar spine, dysplastic pedicles, the usual concave side dysplasia with hypertrophic pedicles. This, I think, is a great case for a robot, but now comes the big question. So this is still a mobile spine, right? The thoracic curve is still mobile, right? So how do you make sure, like if I look at that bottom screw, is that in?
No, that's why we put it up.
Yeah.
So there's some learning
intraoperative
points
CT
on this
scan was
case.
done. Yeah.
And, we did intra-op ORM.
Yeah. And it was fixed.
Regardless of the robot we use the Medtronic Mazor on this one, is that it's very accurate, okay? But you have to be careful with soft tissue retraction. You have to understand, okay, and you have to, as Ronald Reagan used to say, you have to trust but verify, right? So most of the screws except for one was out.
Yeah.
And so we redid it. And part of the reason why down at the bottom, we got some soft tissue retraction that was going on, and that's kind of what threw it off. And so, again, usually with this case, historically, we'd expose, we would do all this stuff. In this case, we did one big midline incision.
And transfascial screw.
And we placed transfascial screws. And these are modular screws, so you're putting in, and again, I think the soft tissue thing here is a big deal. And so you can see we ended it up at T2. And so we don't expose, I feel like we don't expose as much north and south. And again, I've only done, and now it's been a year, I've probably done about 100 cases. I've not had this, proximal distal junctional issues. And again, I only have a year follow-up. But you'll see on this x-ray, so we ended up replacing that screw. And then we did some serious Smith-Peterson osteotomies to really mobilize the spine. This was not an easy correction. So.
Yeah, so this is what we ended with. As Dr. Lusquin mentioned, 2 O-arm spins for the robot. This is what we ended with. This is the direct post-op images.
So you went down to, is that L3 or L2? L2, yeah, here, okay.
Yeah.
No, it's L3, wait, 5. I can't see the lumbopelvic junction.
Actually, you know what, you're right, it is
It's
three.
L3.
Yeah, it is 3.
So L3, yeah, so she'll have 3 motion segments, that's perfect. I think you could not have gone,
Anyway,
ended up
better.
higher, this would have not rebalanced. This is a severe curve, and again, this is a beautiful reconstruction. Did you have any problems with monitoring?
No.
Her chest wall is actually expanded, which is amazing. How did you do derotation? So for me, this is always the thing, this is a rotoscoliosis.
Oh, yeah. I mean, this
So
is
how do you
actually,
derotate with
that's
this?
a really excellent question. And we had a video, but I don't know if, Mohammed, if you're able to pull it up, but it's really difficult. And again, being a neurosurgeon, I always feel like, you know, I've learned so much from you. I mean, you're a master at doing these, you know, 3-dimensional rotatory subluxations. But basically, what I typically do is I bend the rod and put it on the concavity and then try to pull the spine over. And then here's a video with my intra-op correction. And you can kind of see, I mean, this is not an easy reduction.
So the robot still required a full exposure, right?
Oh, yeah, the robot is just for placing the
Yeah.
screws. You
So I
still
just want
have
to make sure
do-
that people understand that
yeah.
the robot did not make this less invasive.
No.
And in fact, it gets thrown off when there's too much tension. I had that problem.
Exactly,
Too much
exactly.
tension on
Exactly.
the screw trajectories by muscle jacket.
But you can see, I mean, you can see how
Is that
literally.
Dr. Kramer helping?
Yeah. Every single screw is used, and we pull the spine over to, but we really had to mobilize and drill out the facet joints and do pretty significant Smith-Peterson osteotomies here. And it's not easy. You can easily pull the screws out. So you have to slowly, you can see here, there's Dr. Kramer. You have to slowly start to pull the spine over, and you have to do literally like from the top and then from the bottom and then the middle and the top, like you just have
But you
to.
didn't derotate, you just pulled
We
the spine
did.
over.
No, we did.
So did you actually elevate your hands
Absolutely.
and rotate?
Yeah.
Okay,
You
because
can-
I don't
at
see
the
that
end,
yet.
I mean, this is a long video, but at the end, you can see we derotate
clearly
the
have that.
spine.
If I recall too, we
Quite difficult.
Can you use a microphone? Can you use a microphone? Can you use a microphone?
Yeah.
Push down the chest.
pushing on the chest and, you know, for that derotation.
But look, we
Like-
start to derotate right here. See, look. So, and again, I mean, this is an adult, right? It's not an adolescent, so it's very, very difficult in terms of trying
I
to
think
get.
this is a good surgical indication,
Yeah.
and again, these are very difficult
Yeah.
cases. The thing that I'm always worried about, oh, wow, okay, yes. And you just used one screw at a time for rotations. You
Yeah.
didn't have a multi-reduction
Yeah.
tool. Yeah, cool. That's nice to see
Yeah,
that.
so
Good job.
that's it,
Looks
yeah.
beautiful. And she's
And then
doing
I
okay?
think we have recent, Mohammed, did you show the recent?
Yeah, this is
Okay, great.
at 6 months. I will show.
But I want you guys to see the distal and the proximal. I mean, this is part of the reason why I like the robot. I feel like you don't have to expose as much distally and
And the pedicles
skin
along the
incision, if you
concavity
want to
were
do
all,
a transfascial, you should go a bit wider, not to tension the robot on the upper or the
yeah,
lower side.
just a tiny bit, yeah.
So what does the robot do in addition to navigation? Why could it not just navigate those screws?
I mean, honestly, for me, this is what's interesting, and I never predicted this. There is a cognitive load that you have, like with placing the screws, how big, you know, how many millimeters. Like on this case, I mean, there was there was no pedicles on the concavity, and it was derotated. I mean, and plus, I mean, if you think like how many fluoro shots you would have to do, it just takes the guesswork out of it, and you put it in, you plan it. It's remarkable. I mean, if you put the plan in terms of where the screws are placed, it's insane. It's like something out of a sci-fi movie, and I'm more relaxed. You know, I'm not sweating with lead after the screw placement. You know, we put the screws in, I'm very relaxed, and then we do the exposure, and then the hard part is the osteotomy and the corrective stuff, right? So you feel energized. I mean, I know that sounds really weird, but there is this cognitive load that you have, and I think it decreases that. That's been my experience.
Okay,
Yeah.
I take it. Got it. All right, nice case, nicely done. Wow. And I think it's good that you did it. For me, the deformity of the cord in the canal is critical in terms of risk adjustment. And if the cord is a class 3, as Leah Lenke has identified it, the neurologic risk drives dramatically. I tell them 11% risk. Let's have the great Dr. Karami, the great Karami, as he's now called, Mohsen Karami, come up and show us his case. And then we'll end up with a recent case with Dr. Mrozinski. And all our fellows deserve a lot of credit because they've worked really hard over the last couple of days, as in every day, but. Yeah, this from his place. Despite great success, the point is, despite great success, this is a huge effort, and they still misplace screws. And did it add? If you look at the overall thing, this is what Mohsen said is totally. You want to point out what Mohsen said before? Are you ready? Is completely right. A severely dysplastic idiopathic scoliosis, like what we just saw, I would have probably told the patient I'll stage her. I would probably do exposure, careful screw placement. I would avoid the most dysplastic levels, just not put screws in there, and take a CT and let it recover, and then bring it back a couple of days, 3 days later. So Mohsen has an interesting other case.
Good morning. So the next case is a 69-year-old female. She had multiple surgeries for spinal stenosis in the past for the lumbar area. So after 1 year of the last surgery, which was done elsewhere, she came with severe low back pain with claudication radiating to right leg, which got worse, since last year. And then, so in terms of, previous surgery, at least 3 times decompression, break screws. Last one was a year ago at T12, L1 decompression, L2, L3, and then 2 surgeries for the cervical area. In terms of past medical history, she had like psoriatic arthritis, a non-smoker, very active XOR nurse. So we started like, other treatments like exhausted, physical therapy, injection, the other things. And we tried to reduce opiate usage and, trekking poles and biking. So in terms of her pain, it was like ODI 58, very severe disabling pain. In terms of physical exam, there was like a little bit of dorsiflexion of the ankles, weakness, but on the left side, there was like a bit of hyperreflexia. No incontinence or bladder, bowel control. So this is the standing X-ray, AP and lateral, and the focus view. So there is a scoliosis we detailed as well, 15 degrees detailed, 2 curves, thoracic 31 and the lumbar 31. PI was about 69, and you see there is spondylolisthesis at T12, L1, and proximal junctional kyphosis, adjacent segment disease as well. And this is the MRI, thoracic MRI.
So we see significant rostral transition breakdown. And Dr. Louie, are you back again? Let us.
I am here.
Okay, so the question will come to you. So assume this patient had her care in an unnamed, major, well-recognized Midwestern academic center that is renowned for its deformity care by a immediately recognizable major name in deformity surgery. So there's significant rostral breakdown. If you go back to the x-rays, there's a nice compilation, Mohsen, thank you for putting that together, to the x-rays. What went sour? Did they not hit the alignment parameters? It's a little bit of a funky construct. I think she had anterior surgeries like your dream. She had a 2-level anterior lumbar interbody fusion. Then she had far lateral surgery. So this is a very nice looking lady. She's taking great care of herself. And now she has a skewered abdomen and retroperitoneum. And I'm just being a little bit biased here.
Yeah.
She had no custom made cages. Sorry, a little slant at some of our people here. And did they not meet alignment criteria? Should they have gone higher? She has an inflammatory arthropathy. I think she is actually a psoriatic arthropathy patient. She's on anti-inflammatory. She has reasonably good bone stock. She's extremely active. Okay?
Yeah, and Aaron thinks it was because they didn't have customized interbody.
So somebody
implants.
here says they should have had customized
Yeah.
cages. Should have booked them like 3 months in advance and then gotten 3 different cages for each level. But other than that, that might be the case. But she's fused. So what went wrong here? And relatively rapidly, like 2 years after her last surgery, she's had now, outside of the anterior and posterior and lateral surgery, she's, I think, a total of 5 surgeries.
Oh my gosh.
So what went sour so rapidly?
I mean, it would be great to see what her films look like before.
Sorry.
But she's had these laminectomies.
Patient
Yeah.
privacy.
Yeah. She had laminectomies, you said, at
She
2,
had a
3, and
laminotomy at the levels above. So as
yeah,
soon
so there's not much bone there. I mean, if that was performed after the few, I mean,
No, they did laminotomies at L1-2, and I think they dug out L2-3 also. So there's
okay.
been surgery there. She's very disabled now. Yeah, T12, L1, L2-3. Yeah,
Yeah, I guess that explains the spondy that's occurring at 12-1, which is not all that common to see. I mean, I think the difficulty is you have this rigid construct, and then you have, there are L2 to pelvis is polarizing to a certain extent. There's certainly camps of individuals and surgeons who don't believe that they do well long term because of the junctional failure that occurs above. I think this one's difficult because she's had these 2 levels of decompression right above a multi-level fusion. The construct's interesting. I mean, she fused, so they accomplished that goal. I mean, and not to be hypercritical, I'm trying to look at the levels, but we try to restore most of the lordosis from 4 to 1, and it looks like a lot of lordosis maybe near the mid lumbar spine or maybe the upper lumbar spine there.
Yep.
So the distribution of the lordosis may not be optimal, but that may just be what they were able to achieve with the spine they had with some of these revisions. But I think it's because you've got a very rigid segment below and then 2 levels of decompression above, right at the junction to the thoracolumbar spine. And it's just a harsh transition from a biomechanics standpoint at this point, right above the
in retrospect, yeah, with an inflammatory arthropathy that's actually manifest and documented, probably going higher and crossing the thoracic junction would have, I would agree with that, been better. How to fix that now and how high to go? Assume she's metabolically reasonably good. Again, super active person, as you'll see.
Yeah, I mean, this is difficult.
How do you want to fix this now?
I mean, from a sagittal perspective, you could probably just go to T10, which where she probably could have been, but it depends on if you think that this thoracic curve is driving some of her symptoms. And if that's the case, I mean, with 31 degrees, you may be talking about extending up to T4 again, so that your construct is now surpassing the apex of that thoracic curvature.
Yeah. So we talked about that, and Mohsen, you want to take it forward so that because we have one more quick case to show. So significant junctional disruption, sterile discitis, non-septic, obviously, as you said, spondylolisthesis now at like T12, L1.
Yeah.
And very active person. She's an OR nurse from this particular larger Midwestern academic center, well known for deformity surgery. And let's go show us the final ones and see where we are and what happened next. So extensive discussions were had because she had this cervical subaxial fusion, which left a little kyphosis. Wanted to leave some motion segments intact, but we did a posterior only revision surgery. By the way, she had percutaneous rods placed as the supplemental rods, and she had, which bothered her a great deal, as the pelvic screws were placed percutaneously. And what that actually means is that they're actually epifascially, so that they cannot be buried properly under the fascia, especially if they're S2AIs.
Oh, so she could feel them?
Yeah, and she's not fat. So she was actually bothered by that, but she would not complain because she's a Midwesterner originally. So this was kind of a percutaneous add-on. So we took that all out and we replaced the screws totally new. Somehow we did this without a robot. I'm still not sure how. So criticism, did we go too high, too low? Any further thoughts, alignment goals?
Yeah, I mean, I would have stopped around that level too. I think the difficulty now is you watch what happens between C6 and T3
Yep. So
over time. And
Yeah, she's actually done well. Rod, any complaints?
No, I mean, this is.
A robot would have done it better. I'm totally sure a robot would have been way better, aside from the custom-made cages and pre-contoured rods.
I mean, this is a difficult surgery, and I think you did a great job. But again, as Phil mentioned, it's unfortunately, you still have that segment in between.
Here's a number that you might find interesting. This is called that ODI. So we blinded out the dates. Look at the ODI, 58.
Oh, that's incredible.
So this is like a dream patient. And now, final thing.
So yeah, we saw like the patient 2 years post-op. She was diving and then head her head and calcanal. So head trauma, calcanal fracture. So she came to us. We did the X-ray, and that was the X-ray.
So she withstood a rogue wave that crashed her into rocks that broke her calcaneus. So far so good. But yeah, we're obviously doing exactly what you said. The march to C2 is inexorably underway, but so far the junction zone has withstood the test of time. And she's, again, posture aware. She keeps her shoulders in great shape and all that. So far so good.
Fingers crossed.
Fingers crossed. Yeah. I may have to offer my apologies to Dr. Morzinski because he was going to show a case, but we want to be respectful of your time. Dr. Morzinski, are you okay if we don't show the case? Sorry. Thank you. We had a great discussion. I appreciate you preparing that. Mohsen, thank you. The great Karami strikes again. Applause to our fellows. And thank you, Dr. Morzinski. Without question, I'm going to step to the front. It's really cool to have a great friend and colleague here in the city in a different medical system. And Virginia Mason, now known as Common Spirit, it's changing names. It was Virginia Mason and Virginia Franciscan Health. Now I think it's your Common Spirit now, right?
Yeah, we're somewhere in between all of those right now.
Okay, so it's a little name discombobulation. We're no longer Swedish. We're Swedish Providence, St. Joseph, so in Seattle. Dr. Louie is a nationally renowned person in the spine world because he's really done so much in so little time. He has an MBA at the University of Washington. He's done orthopedic surgery residency training in Rush in Chicago, and he's done a surgery fellowship in spine at HSS, the world-famous New York facility. And he came back to Seattle in 2020 and has made an immediate impact there. He's much published and at all the meetings, and a great guy. And he's going to talk about alignment goals, and how to achieve those with planning and new technologies. So it's cool to have an invigorating new voice from a campus that is so close but so far, as I said earlier. So thanks for being here, Phil.
Thanks, Dr. Chapman, for having us. All right, let me make sure my slides can be seen here. You all can see this?
Yes, looks
okay.
Good.
So we're talking about the importance of pre-op planning today. Which is always a fun topic, and these are my disclosures. Most importantly, as Medtronic is supporting this talk. I thought about, another title for this talk really is Alignment Matters for All Lumbar Fusions, right? As we have just seen in a couple of these cases earlier today. And the reason is, at the end of the day, right, every surgery could actually be considered a deformity operation. Right. So whether we like it or not, I always like to say every degen lumbar fusion that we're considering doing, and then I, call myself an MIS surgeon, whatever that means these days, can be a deformity surgeon because you're either correcting a small focal deformity with a small segment, even in single level fusions, you're preventing a deformity, or you could be unfortunately creating a deformity in the future. And so I think it's important to have this mindset, even when considering just the single level, 2-level degenerative conditions, which is, the largest percentage of the patients that we see. And to remember that this is a deformity in one direction or another, and you just want to be on the right direction and on the right side for both your sake, the patient's sake, and society's sake, ultimately. And so, some of these slides are borrowed from Venu and Mani, one of my deformity colleagues, but, why do we care about normal spinal alignment to start with? And part of it is because, Dubusse has come up with this cone of economy where we're able to stand up straight and allows us to sort of stand with very minimal energy expenditure. And when we sort of fall out of this cone and, you try standing straight when you're starting to lean off to the side and think about all the effort and energy it takes to try to not fall at that point. There's so much more energy that's required once you have malalignment for whatever reason, not necessarily from your spine. And so the compensatory mechanisms that we often see from especially like sagittal malalignment, they're really bad, right? We've seen this in the cases that you all wonderfully presented earlier today, right? This craniocervical hyperextension. You see this thoracic hypokyphosis over time. Your pelvis significantly retroverts, which you can see on AP X-rays. You start seeing these this knee flexion, which is sort of this push towards full body imaging these days. You can even see some ankle dorsiflexion, as you can see on the right-hand picture here. And so, right, the lesson is this, right? We have to take a step back when we're forming these smaller surgeries. And my goal today is sort of taking the lens of these smaller surgeries and talking about why alignment matters, because I think we understand why alignment matters in these larger thoracolumbar deformities. We're still trying to figure out cervical thoracic alignment. But really, we see that so much of the thoracolumbar deformities that we're treating these days are iatrogenic to a certain extent, right? There's a lot of factors that come into play, and it's certainly multifactorial, but it's driven by what's already been performed lower in the lumbar spine, right? So we think about a single level fusion, right? There's 2 to 3 main goals, and 2 of them certainly traditional. One, we need to decompress the neurologic compression, right? They're coming in with leg symptoms, some sort of stenosis, that needs to be decompressed. And then we need to achieve stability, right? So if we're considering a fusion, there's some element of stability. They've already got instability prior to the decompression, right? A spondy or lateral listhesis, or we're creating enough instability with an adequate decompression that we need to achieve stability. But I think this third goal is really, really important now, and that is this idea of preserving or restoring alignment. And so, what happens if we don't achieve our post-op alignment goals, right? You see, these poor clinical outcomes, right? You see patients come back with persistent pain and disability. You see this sort of failure of fusion or instrumentation. You see this increased stress, like we've seen both at the top and bottom of these constructs, even though they're short segment. And eventually you'll see breakdown at the junctions, often proximally, right? And we just have to remember, we talk about PJK over and over and over again at magnesium with these deformity operations, but we see it a lot more in these short segment fusions. And so, the radiographic parameters are still clinically relevant. Now, the problem is there's a million of them out there. So how do we figure out which ones we want to use, right? We all know, the PILO mismatch of less than 10. I think that we are starting to see more evidence that this is falling out of favor a little bit, especially given the factors that are driving sagittal malalignment. We talk about, pelvic tilt less than 20, SVA less than 5 centimeters. And SVA is a tricky one too, because there's a lot of reasons why someone could be leaning forward, even from a functional perspective, not a structural perspective, that would drive your SVA higher. People talk about, really importantly, that 2/3 of the lordosis should be from L4 to S1, right? We talk about this distribution of lordosis, or this harmonious distribution of lordosis in the lumbar spine, where oftentimes we'll see 2/3 of that lordosis down at the bottom, and we know when it's been reconstructed and 2/3 is at the proximal upper part of lordosis, it just sort of looks funny, right? People also talk about the upper end plate of L4 being parallel to the floor. So there's a lot of different goals that we can use even in these short segment fusions. And I'm not going to be here sitting today saying, hey, you have to use this one and not this one. I think it's just important to get people to care about even evaluating alignment when you're performing these procedures, right? I think one that's certainly become a bit more popularized recently, based out of this means database, which is a really cool database of normative alignment, by the way, is this L1 pelvic angle, right? So L1 PA, where I think we talked about a goal being half the PI minus 20 degrees or so. And this accounts for both sort of the magnitude of lordosis and the shape of the lordosis, and how that varies with different PIs. And so, to take a step back, right, PIL can be misleading at times because, right, there's all these hidden deformities that may exist when you have single level degenerative changes, right? We all know when the spondy develops or you get these degenerative changes, you lose some of that segmental lordosis at that level. But what we often don't always talk about is the compensation that occurs at those adjacent levels, right? So if we look at these two X-rays here, yeah, certainly L5S1 is probably focally kyphotic, if not neutral there. But look at the hyperlordosis that's present at L3-4 and L4-5 to maintain that PILL mismatch. But once you've corrected and improved the lordosis here with an ALIF perc surgery, you can actually see the relaxation of the hyperlordotic compensation that was occurring at 3-4 and 4-5. And it's really important to take that into account. And you may realize that after proper realignment has occurred, some of the compensatory mechanisms that we often see are no longer all that necessary. And, we've done some work looking at this with our group, trying to understand how the spine moves after these single level fusions. And what we're starting to see is, when we see the correction of a single segment or two level loss of lordosis with degenerative changes in spondylolisthesis over time, and that's been corrected, we see significant changes at the adjacent levels because they've certainly relaxed a little bit from their hyperlordotic compensatory state. And so we look at these fine element analyses that show all these bending motions and moment forces that occur at the UAV of spines that are, sagittally malaligned depending on how you measure it. And so we know that there's all these surgical targets for long construct fusions, and believe me, there's a lot of them, as Dr. Chapman and Dr. Sweden have alluded to, and it can get really confusing. So, I'm not saying, again, we need to do that for these, 4 or 5 T-lifts that we're doing, but we do need to pick a couple targets that we are trying to achieve and not just blindly decompressing and fusing along the way. And so, there have been studies that show even with a PIL mismatch, or depending what your target is, if it's L4 to S1 lordosis, or the distribution of lordosis, we see that there are certainly elements of both shorter term and longer term problems that occur at the adjacent levels when we aren't matching, or we're not paying attention to the sagittal alignment goals, or at least trying to normalize or achieve a certain goal with these shorter segment fusions. And this is especially true in the lower lumbar spine, right, at L4-5 and L5S1, when you have the greatest opportunities to impact change and where most of the emotional lordosis is often present. And so at the end of the day, we like to ask ourselves, well, how do we actually define normal alignment for short segment fusions then, right? If PIL isn't perfect, and there's all these different measures out there, what's the best way to plan this out? I think what we're starting to see now in a lot of these meetings and a lot of these discussions that we're having is, really paying attention to what's happening at L4 to S1. Right. This was a great paper that came out from Pesenti and Lafage and Frank Schwab that looked at, independent of PI, whether it's a high PI or average PI or low PI, whatever bucket you put them in, L4 to S1 lordosis remains about the same, right? So there is this adage of 2/3 of lordosis is from L4 to S1, but maybe that's true in the lower pelvic incidence patients or the average PI patients. But in the higher PI patients, what we see, especially in these more normative asymptomatic patients, is that where we see the lumbar lordosis matching or getting closer to a higher PI value is not that there's greater lordosis at 4-1 and maintaining a 2/3, 1/3 ratio, but we start seeing that there's greater amounts of lordosis in the upper lumbar spine. So, if we think about 4-1, being about 35, 40 degrees in all of these patients despite their PI, perhaps that should be a better goal with the shorter segment surgeries that we're performing, especially because they're the same with different PI buckets. And the important thing to remember is, if you've been using PI-LL mismatch all this time, again, which isn't wrong, right? And you're doing a single level fusion, you can't really impact directly the other levels, right? Sure, you can try to predict what sort of return of compensatory mechanisms or compensatory hyperlordosis may be occurring at the levels above, but still you're often doing like a 4-5 or 5-1 or 4-1 fusion. But then starting to think about, well, maybe if I can just achieve a L4 to S1 lordosis goal because they're similar enough across patient populations. That may be a good start in trying to preserve the adjacent segments over time. This is just sort of from the same paper looking at how the distribution of lordosis across, especially these lower lumbar segments from L4-5 and L5-S1 and L4 to S1 are fairly similar across various PI presentations. And it's interesting, Dr. Namani with our group recently did a study looking at, well, if we try to stratify by segmental alignment, we're not very good. We've got a study by Dr. Leck from 2018 that showed that if we were using PILL less than 10 as an alignment criteria, we were achieving that goal of less than 10 degrees across 18 centers that were part of that study. At 4-5, 3/4 of the time, and at 4-1, 3/4 of the time, at 5-1, 85% of the time. So we're doing pretty good from a PILL mismatch perspective. But if we use segmental lordosis goals, right, 4-5, 5-1, and 4-1, within 35, 40 degrees, we're not very good at that, actually. And the findings and our ability to achieve segmental alignment is significantly different than when we are assessing the ability to achieve our goals from a PILL less than 10 perspective. And so this study included, 18 centers, and you can see the number of patients, fairly large number of patients with 2-year outcomes that we were looking at. And so, the question we get asked all the time is, well, okay, we are in a society, in a healthcare system, nationally, not specific, our individual ones that are asking us for volume, right? Like we want to get patients on and off the table. We want to get patients safely through their perioperative care, and then we want to get them back home as early as possible, not hanging around the hospital. We have so many things that are going on, and we have all these administrative burdens. Well, how do we find time to make all of these measurements, right? Do we sit there and go in our PAC system and manually draw angles? How do we sort of contour our rods, do all of this? There's got to be these technologies that are helping us sort of automize these workflows a little bit. We talked about earlier today multiple perspectives of robotics and spine surgery from a cognitive load standpoint and a pedicle screw accuracy perspective and the ability to safely place screws into dysplastic pedicles. But, in spine care, so much of what we do is not just the carpentry itself, but in the indications of what we're deciding to operate on and how we're going to achieve those goals and how we're going to go about the surgery itself. And I think that it's important to start considering, well, what technologies can help us create a goal and then execute a goal, since we've done such a great job with technologies that are in the operating room to allow us to achieve some sort of goal, but we need to make sure that we're setting the right goals. And sort of as sort of the sponsor of this talk today, I think it's a nice time to sort of highlight the unit technology that Medtronic has, right, where they created this ecosystem of being able to upload images as we do in our system and have all these measurements that are performed for you. They've used machine learning algorithms over time to improve the accuracy of their data with all of these thousands of x-rays that have now been placed in there, and they'll follow your patients over time and perform these measurements. And you can choose which measurements you want to focus on, but you actually have all the measurements to your disposal, right? Again, we're not saying that one measurement is the best measurement for all of them, but it's all sort of part of this puzzle and part of this larger picture. And so you can focus on the measurements that are most important for you, but most importantly, you're not the one sitting there, printing out x-rays and drawing lines like I had to in residency and fellowship, or even on a PAC system, drawing lines, because we've also seen literature that shows that a lot of these automated programs now that are performing this are more accurate than us as surgeons or as trainees performing these measurements. Then you can order these patient-specific rods that are based on the plan that you've agreed to with these engineers. But most importantly, you're able to capture data, right? We longitudinally too, and we talk about all the time, right? What's happening to these short segment fusions once we've performed them, right? There's this push of, outpatient surgery, let's do these as fast as we can. And then we have to remember we need to follow up on these patients, and can we rightfully look each other in the eyes and say, hey, how are our patients doing 1 year out? How are our patients doing 2 years out? Right? Can we turn the critical eye on our own outcomes over time? And I think this type of platform helps us do that, because when it's within the same ecosystem, right, it's following these patients over time, and they can provide you with dashboards and graphs onto, well, here's the correction that was achieved. Is it maintaining over time? What's happening to the rest of the lumbar spine over time as well? And this is a screenshot on how the spinal pelvic parameters are calculated. And you can see they now are able to predict some of the compensatory mechanisms that are occurring, not just in the lumbar spine, but in the thoracic spine, based on, the amount of degenerative spondylosis that's there. And we know in a lot of these adult degenerative, scoliosis or deformity patients, and even in our degen patients, like it's very spondylotic in the thoracic spine, so you may not achieve much of a compensatory response to the surgery below. And even in the lumbar spine, when they're a lot more spondylotic than when they are as younger patients. So they've got these awesome AI models for both adult deformity, pediatric deformity, and degenerative patients at this point, down to S1. And so, again, these are all technologies that can help us, at least from a planning perspective. And again, they now have this ecosystem where you have these preoperative elements. And, we've talked about the robotics and navigation and the imaging perspective from the operating room perspective. But they also have technology now in their partnership with OBIRD, because we know that radiographic parameters aren't everything, right? Like, sure, that may be the topic of this discussion today. And it's still important, right, to think through the alignment of our short segment fusions and certainly our deformity patients. But we have to remember it's how the patient perceives their improvement overall that's even more important. And so being able to link the specific radiographic parameters to specific and a spectrum of patient-reported outcomes, and at this point, sometime with even wearable technology to get objective patient outcomes, is going to be really important as we go into the future. Because, as AI becomes more generative and machine learning becomes more capable, it's really important that we're providing as much data as we can, and then utilizing this data into our practices in sort of a responsible fashion. And so, in summary, I'm happy to chat and we can have a discussion, right? I just want to sort of carry this home with you. You're performing a single fusion, you really want to get the alignment right. And, in my mind now, looking at the recent data, I think that achieving segmental lordosis correction, especially at 4.5 and 5.1, is really important, right? Because you want to take that little bit of extra time now, rather than, as some of the cases we've seen today, where patients have had multiple surgeries, trying to correct it later when it takes a lot more time and a lot more effort, and now a lot more metal and a lot more risk and potentially a lot more problem down the road. And so, every surgery is a deformity operation, whether we like it or not, even in these single level fusions, right? Again, we're either correcting a small deformity in a small segment procedure, especially if we're reducing a spondylolisthesis, where we're working everything we can to prevent a future deformity by understanding the alignment of our lumbar spine, or unfortunately, we are not paying attention to that, and we're creating deformities in the long run. So, thank you. Happy to
Great
chat
job.
more and
Thank
have
you,
those
Philip.
discussions.
Hey, can you go back to that second to last slide? Beautiful.
Oh, yeah.
Nice. This one before that, the gray banded one with the two. Yep. There's a nicely done restoration at L2. Here's some critical questions. It's me. I have to ask critical questions.
Yeah.
I actually go up one, that blue one, the able one. Let's ask that first. So if you go back to one earlier than that. Yeah, so this is my question. Who owns this patient data? My concern is the following. This is not dependent on Medtronic, because I work for other companies as a consultant. One big ethical question that arises now is, who owns the patient data? Is it the hospital? Is it the vendor for the medical record system, which is nowadays, in our case at least, Epic, a privately held company in Wisconsin? Or is it the manufacturer of robotic devices? These actually store their digital information separately from our healthcare systems, our digital imaging files and the EHR. And if I see all these data points being acquired, these are all industry-driven things that have to be separately downloaded with permission of the manufacturer, but the manufacturer owns it? Or is it the patient who owns the data? So who owns the data? Is it the company? Is it the hospital? Is it the purveyor of electronic medical record, or is it the patient? Because this is worrisome to me, because this means that the company, and it doesn't matter whether it's Medtronic or whatever name is there, owns the data.
Yeah, I love that question because I love asking that question because no one has a good answer. But I will give you my answer to this, in that I think it depends on who you ask, right? Which is not necessarily meant to be a cop-out to your question, right? If you ask the hospital systems will say, hey, we should own that data, right? If you ask some of the industry partners, they say, well, we should own that data because we need to learn to get better, right? We need to use this data to help drive the success of enabling technologies in the future. And that in hand goes back to the patient. Well, if you ask the patient's like, well, this is my data. I should actually own my own data, and I am leasing it out to the hospital systems, or I'm leasing it out to industry so that I can learn for it. But at the end of the day, this is my data and I want to own it. In reality, I think what we're going to see is that multiple parties are going to own multiple parts of that data, and it becomes a mess when there's a problem or a mistake happens or there's a complication occurs because of the data. That who bears responsibility for the complication mistake that's occurred? You know, will it be the hospital system? Will it be the industry partners? Will it be the physicians themselves? You know, at that point, all of a sudden, no one's going to claim ownership of the data. So I think we're going to walk into a world where the data actually has multiple owners, and we're not going to be able to track it all that well. And it sounds horrible sometimes to think about it like that, but we may have to be okay with it because that data is being used, hopefully in a responsible fashion, to drive the field further. But this is me very biased, coming from a guy who is a very lazy shopper and likes going online to Amazon and Amazon telling me what they think I will like to buy, and me not having to search all the time because they've taken my data and they've made sense of it. So take that for what it's worth.
Yeah, so no, this is actually a very reasonable answer. The problem is that I think people have not wrapped their head around how complex this actually is. And the companies are going to hide or keep that data that they put into that beautiful right-sided bottom O-arm unless you have a very specific service and data sharing agreement. And the robots store all their data in their separate files. They are not live online in our IT info system. So that's actually an overlooked thing, and they actually get downloaded to central files. A company in the future will want to have all this together in their thing and then sell it back to the hospitals who already pay a bloody fortune to this company in Wisconsin. Dr. Kramer's from Wisconsin, he's responsible for this. But this is and I don't think I'm overly paranoid. I know where this is going. Data is king. Amazon, you mentioned the company. Data is king, rules everything. If you own the data, you own the empire. So this is a data fight ultimately, and who owns that data? And I actually am the naive person who thinks patients should own the data. Nobody owns this data except with a patient's permission. But I know where this ecosystem, as clever as that is, goes, and that's a company will sell this back to the hospitals once they have enough of a monopoly. Go for it. Mosen has a question.
That was a great talk. Thank you so much. So when I started, orthopedic surgery, so I saw the industry making like jigs and, plates custom made according to the measurement pre-op. I even offered them just do the, allograft pre-shaped for the VCR osteotomies. So that was like very good idea. And then just making the rods, custom made rods. Titanium and then cobalt chrome. But the thing is, these are on paper goes very well. But when you try to push those things, roughly with force to the pedicle screws, it's gonna cause, pedicle screws pull out and broken pedicles. So on paper, these are very good things. For sure, it's gonna work for some patients like short fusion. But for long fusion, pushing the rod, forcing the rod, even like titanium, which is very flexible, then like cobalt chrome, it's gonna cause, screw plots and, the broken pedicles.
Yeah, I mean, I think that the rod bending is really crucial, right? Because if you start trying to correct to a rod and the screws are not there yet, one of two or three things is happening, right? Either the correction is inadequate that has been performed so far, right? It is too rigid or it is undercorrected, or something has happened intraoperatively and you have a pre-bent rod that is now not accurate to whatever has now been achieved in the operating room. And I think, there are also really important tools that need to be able to allow us to assess the alignment of our entire spines in surgery, right? Because when something like that is happening, exactly as you mentioned, you don't want to force anything, right? You start forcing things, problems happen, things break, that's bad. So we need to take a step back and figure out, well, what's driving the difficulty in the passing of a long rod at that point?
So one question about waste and cost. So these pre-contoured implants, I'm not going to divulge direct numbers, but in our system cost about tenfold of our negotiated prices for rods and cages. So that's not a trivial point. Friends of mine who use these or have used these customized patient-specific implants, which sounds really cool, tell me that they usually get 3 implants sent to them by the manufacturers, and then they still have to rebend the rods, for instance, or have to just, quote, make the cages work because they don't fit quite right. So how wasteful, how beneficial is this really when the one token advantage might be that you can put the rods in easier or that there's less rod fractures, which is, again, a contested argument since it's not been really checked in the longer run with non-interested comparison study members?
Yeah, I mean, that's a really big picture question. I mean, right, everyone has eyes on their contribution margins in surgery now, right? There's a huge eye on, the costs of being able to achieve the outcomes. And are we able to achieve, how can we achieve similar, better outcomes at the lowest possible cost? I don't have a great answer for that, aside from, look, we certainly have to bend some of the rods we bring in sometimes too, but now we're not bending from a straight rod perspective, right? From an ergonomic standpoint, right? If we are always bending from straight rods all the time over a course of our careers, is that increasing our risk of musculoskeletal injury? I don't know. I will take a step back and say, at the end of the day, maybe the rods, which are awesome and can help, is just the means to the end. And as you say, it's for the data, right? Because the data is king. And the rods are there to help drive the data collection and to understand the data, or at least provide data over time. But I do think that we as surgeons and leaders in our hospital systems need to be responsible with our innovation and be responsible with the technologies that we bring in. And I think it's fair, to try some of these for a bit and then take a step back and actually evaluate, okay, what is the ROI that has been obtained by using this technology, right? Is it a pure cost perspective? I think that's a dangerous calculation to make because that'll never win. But in terms of outcomes and other harder to, is there a benefit there that can override the cost that this is driving to our system?
Yeah, no, it's an unresolved issue. And this is an excellent talk, really. And, can you go forwards to your final slide there? One worry that I have about alignments, which are critical because our spine is a magical alignment organ. It's an organ system. It's not just a chain of bones and discs and neural elements running through it. One worry that I have is that by fitting to alignment or subjecting oneself to alignment and alignment goals, we may increase the number of fusion surgeries done. And I'm very worried about that because that's something that I think may overutilize fusions even more. Dr. Morzynski was going to show you a case of a physical therapist who had 7 lumbar fusions done over a 8-year period. It's hard to imagine. I'm so sorry that we couldn't show you that case. It's a recent case. Very frustrating to do because it was done in a different healthcare system, doesn't matter where. But 7 fusions over an 8-year period in the lumbar spine, woo, that's harsh. And still, patient needed a major redo surgery. So I don't know, are we overdoing it by listening to alignments only? And aren't we as human beings maybe way more complicated and require far more multifactorial input and assessment, like inflammatory diseases, like what Dr. Morzinski and Dr. Kramer said before, sarcopenia? Isn't that a factor that we're not looking at right now?
Yes to everything you asked. I think that we are fusing too many patients. I feel that a hyper focus on alignment drives us to fuse more patients unnecessarily. I feel that this high number of fusions also drives healthcare costs and poor outcomes over time. It does feed deformity surgeons. And yes, I do not think that we are spending enough time focusing on the soft tissue elements of what happens to the spine. I will say sort of, obviously the goal of this talk was talking about alignment. In practice, I've mentioned those 3 goals with any surgery is you've taught us over the years too. The first is still decompress, right? We are doing surgery most often because there's some sort of neurologic compression. A fusion should achieve the next goal, and that is if there's any stability that needs to be achieved. But at the end of the day, right, we should be focusing on decompression first and clearing the neurologic compression because that's what's bringing them in. And then it's, okay, what are the other factors going on, and does anything else need to be achieved? And so alignment would be a secondary goal to all of those. And I just hope for society's sake that we are still prioritizing those goals as we should.
Well, this is a wonderful talk. It's great to see you again. Hopefully next time in person here at SSF. Thank you for our audience. So thank you to Medtronic for sponsoring this. And it's very educational. Despite all my notorious critical questions, that's just the old ogre that I am now. But I thank you for that. It's very thought-provoking and always fun to see you, and many, many great points in there for our learning. Thank you so much, Philip.
We'll see you all soon.
Have a great day. Bye-bye.